and that's really how we work. We sell through local distributors, and we work with whoever really knows the best ways to get the products to the high need facilities. I'm going to talk a little bit today, though. Oh, we're already up with my recommendations. So just ignore that for a minute, because we'll get there. I'm going to speak, though, today from a reconstruction standpoint. Oh, we're jumping ahead. Don't look, just ignore it. I'm going to speak from two perspectives. The first is leading DREV. My background, as mentioned, is in engineering and also product design, and I have a very strong philosophy about a user-centered design approach. So I'm going to talk a little bit about that. But then also, Maud mentioned that I worked in Iraq in 2004 and 2005. I was a diplomat. I was a peon diplomat, though, a worker bee on electricity reconstruction. So many of you who remember that know that it was a challenge, and there are a lot of mistakes made. And the interesting thing, though, in talking about electricity reconstruction, and where I think it's relevant to our conversation today, is that that sort of work is actually fairly similar to product development. I see products as solving problems, and with a medical device, you're trying to solve a medical condition or address a disease. And you can design the greatest product, but if it doesn't get to the people who need it, it doesn't get used, then you haven't solved a problem. In electricity reconstruction, the problem is you want to get power to the people who need it, the hospitals, people. And in 2004, 2005 in Iraq, it wasn't just serving the existing need, but there was a huge spike in demand too. And the product was electricity. And the product itself, when we talk about products and medical devices or whatever that problem you're trying to solve, often we focus on the technology, but that technology is part of a system. And so with devices or technology, you need the skilled people, you need the facilities, you need to worry about distribution channels and consumables. With electricity, you have to think about transmission. You have to think about distribution, and there's a lot of things that happen between a power plant, or even making a power plant run, having fuel to put into it, and someone being able to flip a switch and their air conditioner comes on. So I'm going to mention two significant challenges I see in health planning and reconstruction, particularly from a kind of product-centric view. In reconstruction, rarely are consumers or hospitals able to purchase the devices themselves. So it's a situation where devices are getting donated, and donation sets up a challenging situation. The WHO says that only 30% of donated devices ever get turned on, and 10% of devices actually get used the way they're intended. So, and if you think about the kind of system of products too, why does this happen? Why is there such low usage rates? And one of the reasons is there's no one there to do installations properly. There's not necessarily thinking about how the product is going to be used, how it's going to be maintained. But fundamentally, the product isn't serving the needs of the hospital or the clinic that it's being delivered to. An example of this is most medical devices are designed for hospitals like the medical center here. They're not designed for hospitals that have voltage surges or have intermittent power or have a shortage of nurses, which we've heard a lot about. And that's actually one of the things we've been addressing at DREV, is really understanding what the user needs are and designing for that. The second challenge, especially when we're talking about reconstruction, is traditionally the approach, and we've heard a lot about this in the last day and a half, has been top-down. And this makes sense. The kind of textbook approach started when there wasn't this global communication and global network we have now. And I think you're hearing from all of us a plea for a different approach, one that's more based on user needs. And we can do that now. We can communicate. We can better understand what's happening in hospitals in Syria. We can better understand the conditions and track that and plan for that. So I'll move to my recommendations that you've been teased about here for the last few minutes. And I have 6 of them, just so you know where we're going. So my first recommendation is start the need finding and planning as soon as possible, which is why we're all here. And I also want to say, clarify what we mean about reconstruction or post-conflict and when it will start. There's been a lot of conversation too about hurrying and trying to get products and facilities and resources to the hospitals that most need it. And this is totally understandable in the face of tragedy. The one thing I would caution is that often for success, you have to spend the time up front planning and understanding needs and understanding conditions and working with the experts, particularly the ones on the ground who really understand the situation. And of course, that can be challenging with this tension of hurrying. But the great thing is we are starting now, and we should be tracking as much as possible the conditions so that when there is an opportunity to start the reconstruction, we can very quickly. My second recommendation is to understand and prioritize the needs of the population and providers, and then keep checking. So the first is to understand what are the medical conditions, what are the diseases that the population really are most pressing to be addressed, and prioritize that, and then design the health system around that, whether it's technologies or skills or facilities, like we talked about. You know, in design we talk a lot about users, and I think when we talk about healthcare we often think about users as the patients, but the primary users that we need to be designing systems for are the medical practitioners. And that also includes the biomedical engineers, for example, who's going to maintain products, who's going to maintain facilities once things are set up. And then keep checking. I think we have a tendency as a community and as planners to set a strategy and then not revisit it. And you want to keep going back and testing assumptions, and I'll talk about that a little bit more in a minute. My next recommendation is to map the stakeholders. We know there are so many, and both at a high level with all of the different actors and agencies, but also in terms of a hospital or in terms of getting a device delivered. You can think about it at all different levels. And the stakeholders are, who are they? What value do they bring to the system? And what do they expect in return, and how are they related? So in engineering, in engineering we have a tool called the customer value chain analysis, and this is something that as designers and planners we use at DREV from the very beginning to understand who are the users, who are the decision makers, how is everyone related. And one of the values of a customer value chain is to figure out how the different actors are aligned. And I think another thing we've been hearing over the last couple of days is that the stakeholders aren't necessarily aligned. And so figuring that out early and trying to bring alignment either through financial incentives or through some other kind of structure, if you can do that earlier, that's going to result in much more success later on. If you can't bring alignment, at least you know, and you know going into the process where the challenges are going to be. I just wanted to show a quick sketch of what a customer value chain looks like. It doesn't have to be something fancy on the computer. It can be on a large sticky note like you see here. And if this is something you're interested in, let me know, because I can give you a paper that walks you through how to do it. My fourth recommendation is design for a dynamic system of flexibility. And this came up yesterday with the Director General of Public Health. And we've all been kind of talking about, if you're going to build something big, test it on small scale first. And I'm going to show a model called the design thinking process, which came out of Stanford University. And you can see empathize, which is who you're solving for, understanding the needs. We're talking a lot about understanding what the problems are on the ground. Define what the needs of the patient or the doctors, what they are. And then you see ideate, prototype, and test. This is figuring out how you're going to solve problems. The power of this, though, is you have to keep iterating. Often you'll test something, you'll test what a facility should look like, you'll test what a new intervention might look like. You heard about some incredible social enterprises earlier. If you're looking for particularly a novel innovation, you can test it on small scale first and expect to iterate, expect to possibly pivot, which is something that's not common in the big kind of systems planning about reconstruction. And going back to my experience with Iraq's electricity reconstruction, there was a lot of very big projects, power plants that were set from the very beginning that there weren't fuel to run. And this was one of a very painful example of how, if you're not thinking through the systems and understanding what the conditions are and what the constraints are, it's going to take much longer to have the impact you're seeking. Fifth recommendation, for products, consider the product life cycle planning. I love that Fernando Cantu yesterday talked about life cycle for humans. I'm going to encourage you to think about life cycle for products. If you're someone who's looking at purchasing devices for a facility or reviewing and making recommendations, I want you to think about how are the products going to get there? How are the spare parts going to get to the facilities that need them? And just to give you an example, one of the projects DREG worked on is phototherapy for severely jaundiced babies. And the old style kind of phototherapies use long tube bulbs, fluorescent tube bulbs. Those bulbs need to be replaced every 4 to 6 months. In Kampala, those bulbs each cost $200, Kampala, Uganda. And a single device that's effectively being run and maintained needs 6 of those bulbs every 4 to 6 months. So that was never part of the original equation in purchasing the devices. Installation, who's going to do the installation? Ensure that the staff has the capabilities and the desire to use the product. And then you've got the cycles of using and servicing and maintenance. And then eventually end of life. We have this tendency, particularly with capital equipment purchase, to be very excited to purchase it to get it installed and then forget about it. And that results in the equipment graveyards that we often see in many hospitals. And then my last recommendation is, what are the opportunities? I think what's so exciting is hearing about social enterprises and learning about proximity and thinking about, we tend to focus on what the challenges are, but there are so many opportunities. And yesterday, one of the questions, or one of the comments was around how there may be spare capacity with families. And there's an NGO called Noura, based out of India, that trains family members to provide post-operative care. And they've had incredible health outcomes, at least there. And then Nadine's already talked about proximity. But I really plead for a landscape study, and I actually wrote this before I asked the question, but I was hoping that in the last session, I was hoping that someone would be working on a landscape of social enterprises around health. And I hope that's something UAB would consider taking on, with support, of course, from all of us, right? So just in conclusion, I know many of my recommendations are intuitive and focus on the basics, but I just kind of want to summarize them because I think it's always good to be reminded of our basics. Invest early, understand the needs, the constraints, and the problems of the users, and then keep checking back about the assumptions and those early findings. Stay flexible and adapt. In engineering, one of the key phrases we say is be comfortable with the ambiguity. It can be difficult to not commit to a specific plan, but being a little bit comfortable with the ambiguity, or at least having not just plans A, B, and C, but D, E, F, and G. And then lastly, leverage the social enterprises and the opportunities. Thank you very much.
Thank you so much. Last but not least, I would like to give the floor to Professor Zaman to share his thoughts on this. Professor Zaman, the floor is yours.
Thank you so much. All right. Well, it's a real pleasure to be back at AUB. I was here about a year and a half ago, and it was really a wonderful, wonderful opportunity. And I'm really glad that I'm back at this. And also this conversation here about the leadership of AUB in thinking about conflict and post-conflict rebuilding is really remarkable. I'm going to speak on behalf, or not certainly not on behalf, but as an academic here. And I'm going to talk about some of the things that were mentioned here, particularly yesterday and today, on capacity building. So how do you really take capacity building to the classroom? And how do you sort of create the next generation of scholars and entrepreneurs and innovators who are going to make an impact not just on the conflict and post-conflict in Beirut, but the next one, or the one after that. I hope we don't get to see a whole lot of those, but the reality is that that's how the world is progressing. So how do you really do that? Now, when we think of conflict and post-conflict, we realize that academia has played a part in certain areas better than others. So medicine and nursing, and in some cases architecture, has done a lot better than engineering. Even within engineering, mechanical and civil perhaps have done more than biomedical engineering, despite the fact that we recognize that that's an important area. So why is that? And how do we sort of start to change that? And that's sort of the conversation that I have with myself, with my students, and I hope I'll have it with you in the next 10 minutes as well. The first question I want to sort of answer is, so what's special about this area and why I'm doing it? So first, I grew up in Pakistan, a place that has seen, right when I was growing up, nearly 2 million refugees coming from Afghanistan, and the problem hasn't gone away. I've also had a chance to work in some of the post-conflict places in Africa. So that has really sort of shaped my own understanding. And I'll sort of walk you through some of this questions. So I'm going to give 3 specific examples. The first one is awareness, the second one is about development, and the third one is about engagement. So let's start with awareness and context. And when I mean awareness and context, I don't mean a single seminar or perhaps a video or even a lecture. I'm talking about how do you create awareness among students throughout their academic career so they're able to make a contribution to these real challenges. Not just through a single class, but as part of their curriculum. Now, anybody who has been involved in designing curriculum or creating new programs knows that you cannot just make up classes or you cannot just sort of create new programs. You really have to really think through that. So let's take an example of that. So this is the typical biomedical engineering curriculum in the United States, a 4-year degree, and a similar one that you'll find in engineering here in AUB as well. So you have 4 years, and typically in the 4th year, students in biomedical engineering would take some kind of a challenge that they face in the society, largely in a high-income country. They would do some hands-on work, and it goes back, right? So this is how the circle works. This is how the engine of innovation typically works. And the challenge is, of course, that there's very limited challenge on global health issues, certainly of conflict and post-conflict issues. A lack of understanding of what policy is. They think that if you come up with something last night, it should be by the bedside tomorrow. Understanding of context, understanding of sort of real challenges. And of course, there is little integration of a 4-year curriculum. A bigger issue is, of course, that it's a missed opportunity because students really want to contribute, students really have the capacity to contribute, and perhaps we have responsibility for them to make sure that if they choose so, they have the ability to contribute. So how do we at Boston University are thinking about this? So in this figure, I want to sort of draw your attention to 2 things, the size of the bubble and the color of the bubble. So what we've done is we've tried to introduce a curriculum that focuses on these issues, largely of global health, but also a little bit on conflict as well. So yellow means a new course, elective. Blue means a new global health content. Red or pink is a hands-on activity, and green is a little bit of policy. So in the first year, when you have to take a lot of electives, we have introduced courses such as Introduction to Global Development or the role of engineering in conflict or things like that, right? So that's an idea. In the sophomore year and the second year, when they already have some hands-on activities, we've introduced modules that are focused on global health. They were already going to the lab. What we have done is we've introduced modules that allow them to learn about some of the complexities and open-ended problems that we face from Ghana to Indonesia, from Pakistan to Papua New Guinea. In the junior year, no new courses, but an existing course that brings a little bit of global health connection. So I teach a course, for example, on transport phenomena or mechanics, and instead of focusing on beams and struts, we focus on the availability of local materials to design a better crutch in Zambia. So that allows us to really take a local context and really bring issues into the classroom without changing the content or the rigor. We don't want to sort of give them an education that is not of the desired quality, but we want it to be contextual. And I'll tell you how we do that. And certainly in the senior year, we focus on a number of hands-on activities as well. In the last 5 years, ever since I have started this program, the number of students, when I started this, was 2 out of about 100 who were working on global health issues. Now more than 60%, more than 62%. So it's a 30-fold increase. And that is driven largely by student interest. I take no credit for that. It's driven by student interest, and we were able to sort of converge in that and happen that as well. So one of the ways in which we are doing that is what we've created a sort of a global health repository with the help of Harvard Hughes Medical Institute. And the idea is that anybody on Boston University campus, anybody who has ever worked or have seen or faces or looked at a problem that they think is an engineering problem, writes to us, fills a form, we talk to them, we convert that thing into a classroom problem. And what we do is by doing that, for example, I talked about sort of crutches in Zambia or somewhere, and we make it a problem so that somebody who's teaching a mechanics course is able to take that and plug it into this classroom. So this is how we incentivize faculty, because faculty are really interested in doing that, but they don't have the time to really look at these problems. So this database allows them to choose the problem that they want and plug them into their classroom, whether it is for motivation for an exam, whether it is for creating a new sort of understanding, or whether it is to create a thesis project. And we've been able to introduce that in all 4 levels. So that we piloted it starting last year, and we've done it at the freshman, sophomore, junior, and senior level. So this is the back end. Somebody said they wanted a mobile bike ambulance, and somebody submitted it. We converted it into a problem. Same thing with the directly observed therapy. They can choose whether they want to be involved, and the students have the capacity to go back to the person who proposed, should he choose, as well as the communities that they see these problems. So students are able to sort of talk to these people, work with these people, and in some cases even go to these places. But most importantly, they're generating awareness of these issues and building a sense of capacity, how to work with these open-ended complex problems, not just the one that you see in the textbook. So I want to sort of move to the second part, is out of these things and out of sort of this conversation in the classrooms and research areas, there is a necessity to really think about how do you create research problems that focus not just on single technology or a single solution, but rebuilding the system as a whole. And since we're talking about public health care and health in general, one of the problems that we work on is the issue of improving access to quality medicines. So this is a picture from Syria, well before the conflict really took a turn for the worse. Right? So you see a whole bunch of medicines without any proper storage condition, without any sort of mechanism of proper identification. And this really leads to long-term problems, whether it is presence of counterfeit or substandard drugs, whether it is sort of the loss of life or development of resistance or any of those things. So how do you handle that? And when you're dealing with conflict and when you're dealing with issues of sort of turmoil, the health system starts to crumble. And one of the things that happens is often the availability of goods and services that starts to get compromised. So you see that in Burma, you see that in Papua New Guinea, you see that in this region as well. And you see sort of all kinds of problems. You see sort of bad manufacturing that you see on the left, top left, you see expired drugs, you see sort of counterfeit and fake drugs being marketed, and you see lack of regulation. So out of these questions, again, the point that both Nadine and Krista mentioned of pull and push and of local needs and sort of really working in the field, out of these things came our technology that we are calling pharmatech, which is aimed at accurately and affordably testing quality of medicines at all points in the supply chain. Not just at the consumer, not just at the first point of entry, but at any point in the supply chain. And be able to do that at the same level, an HPLC instrument would do that. So HPLC instrument is anywhere from $150,000 to $200,000, requires grid power and extensive training. We're able to do that for 1/100th of the cost in a matter of 15 minutes. Again, we cannot do everything HPLC can do, and one has to be humble and recognize the limitations, but we can certainly provide the first line of defense before it starts to penetrate in the society and causes long-term damage and harm. So the idea is that we want to strengthen the system, and we want to work with whatever regulatory mechanism there is, even if there is a very poor one, and empower those people to be able to test at all points in that supply chain. Right? Be it the consumer, the first point, the second point, and so on and so forth. And we've done these trials in Ghana and Indonesia, and hopefully soon in other places as well. And the last thing I want to mention in the last couple of minutes is this idea of how do we put all of this together, both from an academic standpoint and engagement with local policyholders and policymakers. So Nadine mentioned something that is very powerful, is that this whole notion of parachute health doesn't really work. There's also another thing that we are very sensitive to, and that is sort of this new colonial idea that somehow US or Europe or anywhere else has figured out all solutions to the problems, and either you do it that way or you're really going to be in trouble. So the idea that you want to work with local sort of policymakers and stakeholders, as Krista mentioned, and really empower them is very powerful. And this was mentioned early in the morning as well, in the first session, this notion of working with sort of whether it is last mile health or whether it is partners in health. So we are working with them, and what we are doing is we're trying to map out how would you increase at a systems level access to care. So you have a pregnant mother who needs to go to a hospital. What does access mean? Access means access to education. Access means availability to go there. Access also means access to good medicine. Access also means access to a good healthcare provider. At a systems level, how do you do that? What are the knobs and tools? So what we've done is you start collecting data with the help of local stakeholders, and sort of they go into these models, and not going to go into the detail of that, but happy to explain. And they go into these ideas, and there are a whole bunch of variables, and they go into the hands of policymakers, something like this. And you can sort of play with these knobs. These are typical system dynamics diagrams. And that tells the policymakers what are the various knobs that they can play. Given the fact that the resources are limited, should they invest more in education or in improving quality of medicine? Oftentimes, we would love to have money for all of them, but we don't. So tough decisions have to be made. And I'm not in the business of making decisions for anyone. What I am in the business of is providing tools so that better decisions could be made. And that, I think, is a fundamental role of academia, is to empower people so that they can make better decisions in their lives and through better policy and academia, and certainly AUB has done a phenomenal job in doing that. So at this point, people typically have conclusions. I don't have any. I just have two thoughts. The first thought I have is that context and environment is absolutely critical. As we start to think about a new program of education, of training, of sort of creating the next generation of scholars, whether it is at AUB or Boston University or anywhere else, we have to recognize that this is not going to work in a vacuum. This has to understand, this has to connect with a local context. And the second one is the problem-solving approach. So we've been talking about engineering and technology, and that is really remarkable, but that itself has to be integrated with social sciences and humanities, public health and sociology. And that is absolutely critical. As much as I like technology and I'm a user for it, there was an article in Guardian 2 days ago where it said, a smartphone is great, but it's not a replacement for a midwife. Right? So you really need to understand the smartphone really does remarkable things, but it doesn't solve all of the problems, and you have to really appreciate that as you think about moving forward. And these are the people for, I'm deeply grateful. Thank you very much.
Very interesting, very provoking. We'll open now the floor for questions. We have some time. We'll take the questions and then we'll have our panel address them. And then we'll have a very brief concluding remarks. Please.
Hello, my question is actually for Krista. You said you sell your product for $80 versus something that it competes with the $1,500 one in what it gives. Did you get any criticism or did you get fussed by the private industries that actually sell the other products by bringing such a good alternative at such a low price?
So our products are similarly priced. So I mentioned a phototherapy project we worked on, and that costs $400 in India and $500 plus shipping and tariffs. And that competes with devices that are in the ballpark of at least $1,500 US, but as much as $9,000 in Nairobi. So in the early days, we were ignored by the big companies. And I've always, like we talked about in the last session, the social enterprise session, I've always tried to take the approach of we're addressing markets that are previously unaddressed. And if anything, we're expanding the markets for more competition. And as we've become a little bit more mature and we've got a bit more of a reputation, we are starting to do deals with bigger companies and partnerships. And my approach is we're not competing, we're helping build.
My question is to Dr. Mekho regarding the development or moving from the AUB Medical Center to the AUB healthcare system. I'm a bit surprised, whereby you're envisioning a system which is essentially infrastructure rather than performance or process. Particularly, I'm concerned about the community level. Buildings, equipment, technology, but where is prevention? Where is health promotion? Where is dental health? 50 years ago, I visited a health center in Finland where about half the size of the health center was involved dental health. Training people how to brush their teeth. I mean, these are the sort of things that we need in the communities, not more technology. We need education. We need health promotion. The second point I have, Dr. Mekho, with your system is that we're not working, despite of the war, despite the fact that we have 70,000 doctors less, but we're not working in a vacuum. This is not a system that is expanding in a vacuum. Those are the things that are of concern to me, and linking the AUB name, which has such a heritage of community health work, to such a system is very surprising. I'm sorry to say.
Well, I know every idea at the beginning is very difficult and very surprising, but you have to, I believe, the first question, by the way, you're right, that the system has to cover the whole thing, including education and prevention, but that really, the whole system takes care of it. It's not only at the medical center in Beirut. The problem, the way I see it, that AUB looks at the whole thing, that people, they have to come to AUB. My father-in-law in 1942 from Iraq came to Beirut, and that is expected. What I'm saying is really that you can expand the whole system, going into the communities on different levels, and create your own brand. For instance, regional hospitals, they could be, by the way, they could be in Beirut or beyond Beirut. At these facilities, either regional hospital or regional treatment centers, they can be anywhere in Lebanon or beyond, but they will be associated or related to the medical center. They will be all under the brand, the umbrella of the medical center.
Read about the history of AUB. 1930s, Professor Stuart Dodd went to Syria and developed community health programs.
Okay.
Okay.
Well,
So good.
where is that?
We have this
Where is that?
What I am saying is really open the borders from the medical center here in Beirut and go beyond Beirut and beyond Lebanon if you can.
It's not just technology. It's not just technology.
No, it's not only technology, no. Technology, staff, and services. All levels of, let me give you an example. How can you expand into Syria if you want really to go, when the peacetime comes? How do you want to go to expand from Lebanon into Syria? Do you expect everybody to come to the medical center here? Or really you have to see yourself going beyond the boundaries of the building around you or the building?
There is a vast history of that AUB has done in the past that you have to learn about.
Okay.
This is not the time to discuss.
Thank you. We could discuss that over lunch. Dr. Tafrouz, you have a comment?
Thank you for the very interesting presentations. I'm Bassam Tabshouri, Director of Medical Engineering at the American University of Beirut. A lot of things that you talked about, I have shared in common. I have went to Iraq, spent 6 weeks, so I understand the background you're coming from. Now, regarding the innovation, which is a very important point, it really needs engineering and it needs an ecosystem. In this respect, this is more of an announcement. We have formed a committee under the Lebanese Healthcare Management Association, and I'll take it as an opportunity to announce a conference which will happen hopefully early March about having a hub in Lebanon and the region for healthcare technology innovation. Thank you.
Hi, I want to thank everyone for this and her wonderful presentations. My name is Mohammed Skefi. I am a Beirut Arab University final year medical student. Okay, I want to direct my question towards Madame Nadim. Okay, the way for a striking success is to be passionate about the idea and believe in it, right? So, but there should be centers of innovation where any innovator can get access to. These centers must have high yield technology and should be multidisciplinary. So, as an example, I had won the IDEA competition 2015 with the patient-doctor idea, increasing the efficiency and accuracy of doctor and benefiting the patient in a great way. But I was not able to continue my startup, for I had a lack of backing. Thank you.
I think what you're alluding to is a problem that exists, but is the landscape is changing, and it's when we talk about sort of frontline innovation. When you come up with a great idea, something that you're passionate about, something that you feel will make a difference, and you may have proven in a pilot or a small project that it does, but then where do you go beyond that? And where does clinical entrepreneurship develop beyond the idea? How do you take that from a simple product that you've done to commercialize it or grow it further so that you can have that scalability and that reach? And I agree with you, before some time that was difficult, and to some extent even it was frowned upon that doctors could be viewed as entrepreneurs or innovators, because all you should be focusing on is operating. You shouldn't be thinking about any commercial activities or any activities that will allow you to go beyond the operating room. But I urge you to, I want to impress on you that it is changing, and the landscape is changing. Definitely in the United Kingdom and the United States, we do see that now where, and it's only up until this year that they have approved a role called the clinical entrepreneur, to allow us to wear that hat, to be able to go out and speak to industry, to speak to industry partners, to speak to engineers, to collaborate with other universities and fundraise and raise money, learn all of those activities that we don't learn as doctors or as clinicians. Lebanon in itself, I think, has made huge strides in terms of innovation. And I would urge you to look at things like the UK Lebanon Tech Hub, the BDL. There is some phenomenal work, and quite frankly, our idea approximately was born out of Lebanon and is a Lebanese-funded innovation and project. So we're very proud of the fact that we've been able to be funded by the Lebanese government to take this project globally, and beyond that as well, to be able to create jobs and create relationships with people in the region and beyond. So I would urge you to look at those resources. They do exist, and it is no longer that sort of taboo that a doctor can be an entrepreneur as well. So you should consider those.
This is what is the March symposium about.
Correct. And healthcare hackathons are becoming a very big and relevant part of that. We ran the first one in the United Kingdom back in June. There was one that was run here a few months ago. They are really encouraging doctors, nurses, and I really want to sort of actually congratulate on using the word multidisciplinary, because I think it is not just doctors who can come up with the ideas. Medical students, nurses, OT, physiotherapy, and we work with all of those to come up with ideas and solutions. So, I'm happy to sort of direct you afterwards if you need some help.
Hi, I had a question for Mr. Micho also. You had a really interesting map of, providing healthcare throughout Syria and Iraq. I was wondering if you could tell us some detail about the cost of this kind of project that you envision, or at least the cost of the project you're involved in with AUB here in Beirut, and what timelines do you envision? Because the last panel, the speaker was saying that half people in Lebanon don't even have access to health insurance or healthcare, so it seems kind of surprising to be expanding outside of Lebanon to cover the enormity of these countries without even really having people having access to healthcare in this country.
Well, by the way, I'm not asking you to jump directly from here into Iraq. When you create a system, you really go into steps, and levels. You may actually, I believe, the first step would be into Beirut itself, because there is only one medical center, I believe, which is Premier Medical Center. Everybody knows. But you can have, I believe, other hospitals in this area who are affiliated as part of AUB Medical Center system. And from there, you can expand. I don't believe there is I can now tell you what is the time level, but certainly it will start, the first step will be into Beirut itself as the city. You can expand, you can have hospitals under AUB medical health system, which are related to the system, and you can expand from there. It's, I don't know, I don't have the timeline, and nobody can give you a timeline now, but certainly you start from the city itself and you go to Beirut and other regions, and hopefully if you, I believe that, I would love to see, for instance, a hospital in Syria, for instance, in 10 or 15 years, which is really related or affiliated with the medical center here in Beirut.
Hi, Linda Shakir from IOCC. I want to thank you for all these very interesting presentations. I want to build a bit on some of the keywords, parachuting, maybe integration and sustainability, and just also build on what have been said regarding the expansion of the system. And also at the beginning when Dr. Kamel was saying we have at least 800 primary health centers in Lebanon. So I want to ask maybe Dr. Miho just a little bit, whether is this an idea, is it a suggestion, this plan that was presented, the expansion, is it a suggestion or is it something that is actually going to be executed? And based on, why did we decide to actually expand the system rather than build the capacity of existing structures in the country, as usually, AUB pioneers in that? So that's one. And number two, also regarding how can we actually ensure that there's a need for such an expansion?
Well, I think I'm creating so much trouble, I think.
It's good to be controversial.
The whole idea, by the way, it cannot be, it has to have a complete team to study the whole area, the whole region, and see how you can expand beyond Beirut and other regions, and maybe in the future into Syria and Iraq. It's not an easy answer. There's no easy answer, by the way. I know there are other centers which are part of AUB, but what I'm saying is really instead of to be only AUB medical center, I think it can be expanded to be AUB medical healthcare system, including insurance, by the way. That the people can be within the system, can be insured by the same AUB medical center. And it will take time. I'm not saying it's going to be done in 6 months or 6 years, but the whole thing is, and there are examples in the USA, by the way, where you can see the health system and give it, I don't know if you are in Ann Arbor, you can see the St. Joseph healthcare system, which is now called Trinity Health, that really expand beyond Ann Arbor and beyond Michigan and beyond other states. That these are all under one umbrella. And I would call that umbrella really AUB medical centers, AUB medical healthcare systems.
It's just about, there is already an existing network of centers. Why are we actually creating new ones as opposed to...
This is more, I think, presented as a vision, as something, it's not something that is ongoing.
I'm not saying it's only medical center here, it's the building itself. What I'm saying, you can expand beyond what you have to go when peace comes. You can go beyond that.
I think, I see there are other questions. I just had one myself to Dr. Zaman, going back to the startups idea. When you're including these components into the curriculum and more students are interested again in coming up with projects that relate again to health and entrepreneurship and so on, are you seeing some going into starting their own businesses? And this, I think, goes back to the question that Nadine answered.
So I think, yes, certainly we're seeing in three fronts. So one, we're seeing some, because the program is relatively new, some starting their own businesses. A few numbers, but certainly small. What we are seeing, however, is that these students are now going to larger NGOs and bringing this notion of technology and innovation in there. So some of my students, for example, have gone to NGOs and have started hackathons there that were historically just service providers, or have thought about how to create equipment. Some of them have started, I wouldn't say new initiatives, but certainly, well, I wouldn't say new companies, but certainly new initiatives of training people, right? So how do you go and do that? One of the programs that didn't have time to do that was to work with existing departments in Africa and strengthen their curriculum a little bit, as well as strengthen their program. So they've started new initiatives. Not all of them are technology focused, but a number of them are focused on how do you sort of create better capacity within the institution. So they are working within hospitals, they're working within, some of them have even gone to WHO, and we work very closely with the medical device group in WHO, and our students regularly now intern there, something that wasn't happening. So this, in this way, I think it's again multidisciplinary, going all the way from technology development to system strengthening to creating a culture in institutions that typically didn't have a culture. And that, I think, is a win-win both for us, because our students are learning from policy, and they're also contributing to that.
I think one of the things we're seeing is it would be wonderful to have a global health incubator for innovation, because I think at DREV we're getting approached often by students who have excellent ideas, experts on the ground who have problems that can be addressed, sometimes low-hanging fruit. Maybe that's another thing we could do, is have a global health incubator to support students and entrepreneurs like you.
I'm sorry, we were asked to kind of close the session because of the keynote. We don't want to delay them much. I just have a couple of minutes to have a difficult job of summarizing. I'm glad I'm not in the dean's position who's going to be summarizing the whole forum at the closing session. Good luck with that. Actually, I'm surprised by the speakers, and I want to thank them, because we invited them to talk about planning and technology, and really it ended up being about users. And that is kind of an interesting perspective. So I was kind of getting upset halfway, but then kind of clicked that unless we look at this and we look at what's across the 4 presentations and the recommendations, it's that it's user-centric. So, and I think the model and the vision that Dr. Miho was talking about, and no one gets worried that AUB is not going to start spending money. It's a suggestion. But it goes back to the recommendation of his dad. And if people that need help cannot come to you, you need to pick yourself up and go to them to help them. I mean, that's the heart of the message there. Be it a center or not. And AUB, it's already doing this. We know that with the Surveillance Medical Center. We know that is being done with the Latif Center in Saida and others. And the recommendation is to actually amplify this. And the lack of access to health, actually, in my mind, is another reason why we have to go that route. Because the individuals that do not have transportation to come to AUB-MC, how can we ask them to actually come and pay for the bill at the AUB-MC? And we have to start thinking about taking AUB-MC to them, whether in Lebanon or outside. You talked about the pharma check. It's another thing where I saw that we're taking things to the user. And now we're saying, look, you have these medications that we need to find a way, we need to have technology support us, that we can actually check it on site. And we're able to make a lab on a system that is portable, potentially in the future even accessible, such that these counterfeit medications can get checked. And again, along the same line in Dr. Zan's presentation, we saw that the education is at the heart of this. Unless we change the mentality of our students, I'm talking about the engineering students, and unless the humanitarian aspect and the type of problems that need to be thought is set in the academic system, it will not become second nature for them. They'll keep solving just engineering problems. They will not be solving problems for humanity. And I think that's the key message. And again, the user at the center of that. Design for the user. Krista, we talked about having the innovation coming from the users, for the users, and by the users. And I think that is key. And unless the healthcare system and the healthcare providers and the whole ecosystem around it realizes that there's a mission and goes back to the roots and not seeing this as a profit-generating operation, and we start thinking like DREV, we will not be able to reach the millions that are without healthcare. So unless there's a change, and I think that's the interesting thing in DREV, the message is that we're able to provide quality care and quality technology at a much reduced cost for the users. And I think at the heart of all this, my main take is, and captures all of this, is that Dr. Haram, for us in Lebanon here, reinvented the word frontline. Because in Lebanon, it has a very negative connotation, frontline, as you know. And now we're talking about frontline innovation. And I think what we're hoping for, and our message out of today, is to enable frontline innovation and enable frontline healthcare through technology or any other means possible. I thank you again. I thank the organizers, especially the people running around, especially the people behind the curtains and behind the screen. There's a lot of individuals. There's too many to mention them. But I thank them all, and I thank SHI for believing in two engineers and allowing us the opportunity in a healthcare forum to give this session on technology. Thank you.
If we could ask you all to please take your seats. Thank you for the very valuable morning sessions. As we can see, it's driven quite an interesting discussion and conversation. Next, we would like to invite our keynote speech for the day, Dr. Luay Shabaneh, who will be discussing the contextualizing health-related SDGs to post-conflict areas. We're very privileged to have him with us today. Thank you.
Thank you very much for inviting me to this forum. I really feel very honored to be with you. And it's really difficult to address you after all these brains and innovative ideas. But I will try to share with you some of the lessons learned from our experience as UNFPA, working since 2011 within this humanitarian conflict and post-conflict situations. And I would like to look at the health issue within the SDG framework and see to what extent the SDGs could answer the key questions of healthcare and provisions of service delivery within fragile conflict and post-conflict situations. And let me start by looking at our region, which constitutes 5.7% of the total population of the world, while it produces more than 53% of the world refugees. This scene could tell us to what extent we're really in bad shape. And why this is very challenging for all of us. It is on the other front, could be an opportunity for innovative contribution in regard to the international standards, definitions, SOPs, and so on. The violent conflicts claim lives, disrupt livelihoods, and halt delivery of essential services, including health and education. Globally, there are 1.2 billion people are currently living in fragile context. Therefore, fragile context is not anymore an exception. By 2025, it is expected that 80% of the world's extreme poor will be living in conflict-affected countries. Statistics also tell us that this will rise as we move to 2030, the date which we are supposed to be delivering a world that there is no one behind, and achieving the goals of the Sustainable Development Agenda. Most of the MDGs were not accomplished within the countries of the passing through conflict or post-conflict. Yesterday, I have listened carefully to those who have addressed the MDGs, and I would like just to draw your attention for 2 points here. The first one is the difference between the MDG and SDG agendas in terms of the contract, where the MDGs were some sort of contract between North and South. An agenda that has been identified by experts and financed by the North in the rich countries, and it was an agenda directed to the South to bridge the gap between North and South. But the SDGs was an outcome of a political negotiation took place over the last 3 years. Therefore, the narrative that we hear from many governments that this is an agenda that's imposed on our countries and so on, I'm not sure if it's relevant anymore, taking into consideration that the SDGs, it's a global agenda for everybody. This is why we have 17 goals, 169 targets, and more than 2040 indicators to monitor. The second issue related to the MDGs, taking into consideration the conflict and post-conflict situation, is that the main outcome of the MDG era was more economic progress, but less inequality. The economic development, economic progress was not translated into social return in the form of welfare of the people. The last report of Oxfam on the distribution of wealth and the UNDP reports on the distribution of wealth at the beginning of the era of the MDGs, it looks like the distribution looks like what they have been called the glass of champagne, where the distribution looks like this. After 15 years, the shape has been moving towards the T shape, where 1% of the population of the world own wealth as much as the rest of the 99% of the world. And this is the key difference, I hope, we don't know, but I hope will be between the MDG and SDG frameworks. Going back to our key topic, health systems are often devastated with conflict. Health professionals flee out of the country, infrastructure is distorted, and the supply of drugs and supplies is halted. This is the situation that we usually face in post-conflict situations. Depleted infrastructure and human capabilities, with particular lack of female health workers, including midwives, often lead to weaker health services. At the start, the disturb in the balance between supply and demand is another characteristic that faces countries passing through a post-conflict situation. The other important issue that I would like to highlight is the reinvention or the re-emerging of conflict. Sometimes our interventions, focusing on the very short-term emergencies, creates more, somehow it sustains the humanitarian situations. There is a need to make the balance between the life-saving approach and the resilience approach, so that we do not end up keeping working at the short term by short term and then leaving another issues behind us that will create more conflict and social cohesion in the societies, particularly in two cases. The first one, when there are IDPs, internally displaced persons in the same countries where there are host communities and people fleeing from one area to another. And the second, when people flee outside the country, like the situation in Lebanon here and in Jordan, our region, where a number of refugees are hosted by the host countries. Deficient information and duplication of health information and surveillance system is a common challenge during crisis. This is a lesson that we have learned in the past 5 years, trying to support the whole Syria program from Turkey, Jordan, Lebanon, and inside Syria. Another major challenge is the choosing appropriate intervention. Mostly health interventions in fragile conflict-affected states are limited to humanitarian relief. And as I said, this could generate new conflicts and creates some sort of conflict and distortion the social contract between people and the state, and the lack of trust in the government. Now, this is the challenge that we face. This is the situation that we need to work in. So, how we can address this situation? This could be an opportunity actually for state building and peace building as well. Although it is a very challenging situation, but it could be used if we can coordinate our business, if we can manage our expectations from the different actors and make sure that we are doing our business in a coordinated way. It could be an opportunity for state building and peace building as well. And in particular for the health system. Rebuilding the health system may contribute not only to improved health status, but also potentially to broader state building and enhanced prospects for peace. Because if the health system and health service provision is of high quality and demand driven, this will create more trust between people and the newly established systems and governance structures after post-conflict. The careful design of the core elements of the health system by national governments and their development partners can promote reliable provision of essential health services while demonstrating commitment to equality and equity and strengthening government accountability to citizens and building the capacity of government to manage core social programs. This is a very important input that if we manage to do it, will contribute substantially to the peace building process. Immediate post-conflict period is critical window of opportunity for the government to create peace and to harness the dividend of peace and to restore trust through making right-based health reforms. Health reform is very important. There is a very well-known model for WHO, that is 6 building blocks for the health reform, and this could be an opportunity after the just ending the conflict and entering into the post-conflict situation to use this model and maybe enrich it to use it as a machinery for state building and increasing the trust between the citizens and the government. The accountability of the health system is another area. It includes all stakeholders, ministers of health, NGOs, international NGOs, faith-based organizations, and community-based organizations, as well as the public sector. This governance is a key dimension to making a post-conflict a window of opportunity. Therefore, I think we need to invest a lot of our effort and time in the governance of the service provision, because this could make or break. The whole architecture should be monitored by citizens, supervised by the government, and coordinated across different actors. This is the only way where we can create more trust as we move in the establishment and modernization of the health system after conflict ends. A delicate balance needs to be established between immediate needs for health services in post-conflict settings and the long-term sustainable development. We need to make the balance between the relief and versus development. This is very important to move step by step towards the development of the health service and to modernization of the health system per se. It is important to invest some time in the public-private partnerships as healthcare provider that cover the gap services in the service delivery, and as an employer that contribute to comprehensive health insurance system. And I would advocate that private sector is the best to be the key player for providing health insurance systems. We need to think in a mindset of resilience and preparedness. A comprehensive health programming integrating both humanitarian and developmental approaches will strengthen the adaptive capacity of the national health system to address the current and future situations. So while we are thinking of the relief and the life-saving, we need to keep an eye on the future and to use the momentum that usually is created after post-conflict to make more sustainable solutions for the state. Because usually, from our experience, we know that after a few months or years, donors lose interest if they do not see that there is progress taking place. And let me give you an example from Iraq. The transitional period after the fall of the regime took a long time. This has created new types of conflicts, and the government and the state is being moving step by step to the failure state situation where services are restored, trust between the government and the system is being lost, and so on. Partnerships is a very important aspect that we need to look at the post-conflict situation. And it is important to manage our expectations. Who can does what, and who is eligible to do what. In post-conflict partnerships, and in these countries who pass through, just ends the conflict, Rebuilding the health system requires coordinated effort among government, donors, NGOs, international NGOs, private sector, more effectively. Civil society and community involvement is a key factor to address health needs and to ensure quality and equity in post-conflict context. This requires involving women and men, as well as young people, at various levels of the service provision. There are umbrellas has been developed by the United Nations and the United Nations Security Council, like the Resolution 1325 in the year 2000 and 2250 on youth, peace and security. And there are components and elements in these resolutions that could be used as an umbrella for the involvement of youth and women as peace builders. The narrative related to the role of the UN versus NGOs, government, private sector, I think needs to be tackled carefully, because it might take the situation towards some sort of competition for different elements who have different terms of references and different mandates. Therefore, from our experience, I would like to draw your attention to a number of points. The first one is that the previous experience in development of health system in fragile and post-conflict situations have shown the need to address the weakness in policy, leadership, management, capacity, human resources for health system. It also needs to be complemented by very sound, effective data system for monitoring the rebuilding of the system. Second, donors have not made health system development in such states as priority in the global health programs. Investments are often seen as politically or financially risky. We need to advocate to invest time and effort with the donors that this type of investment is really worth risk-taking. And it is important to look at the rebuilding of the health system from an eye of stabilization and peace building in the fragile and post-conflict states. It is important to think about the long term as well as the short term, and it is important from our experience to look at the trust, the building trust between the people, the citizens, and the government through the quality of the service provision and the equity and equality of the service provided for citizens. This could make the health system as part of the tools of the peacemaking. In fragile and conflict-affected states, programs should follow general principles of system development, preferably through leadership by the Ministry of Health, adhering to standards of equality and non-discrimination is very essential. And respect of the human rights is another principle that should have been taken into consideration. The engagement of women, community participation, and young people is another area of innovative approaches that could be utilized in the post-conflict situations. Data, it is very important, and strong emphasis should be made on standardization of the data generation system and the WISE assessment. In a number of countries, the people in the executive authorities, particularly those in the ministries, they are not in favor much with the investment in data collection systems and assessments in the research, and they tend to push the UN, international NGOs, local NGOs, intellectuals toward investing more in the direct service delivery. I would advocate that these two pillars are important. None of them is more important than the other, because it is important to sharpen our tools and to make our interventions as appropriate as possible and as demand-driven as possible and as in context as possible. The SDGs as an umbrella has emphasized on health maybe more than any other areas. SDG is the main goal, but there are another 8 goals very much linked to health. Health has been looked at as a mainstream dimension in most of the SDGs, and the number of targets and indicators related to health is much more than any other area. Therefore, I believe that the SDGs is an umbrella that is wise and valid, but it has to be put in the national context. The needs of the people are the same wherever we go, but the way how to make them enjoy their rights should be taking place in the context and take into consideration the local circumstances. And I would like to just stop here with the world context, because it's very important. If you take text out of the context, then you will get con, which is a negative. Therefore, it is very important to have each text within, to be kept with the con, to have the context. Having the context is very important. All of us know that people have the same rights, people have the same needs, but how to deliver the rights and how to make people enjoy their rights needs to be going through the context of each community. My final observations here, which I would like to share with you, is that in post-conflict, one of the characteristics that worsen or makes things more complicated is that sometimes some of the governments live for months in the denial status. They don't want to think about the topic, and they don't want to see that this topic is really exists. They live for a few months, and then they respond late when the international community comes in, when the civil society starts talking about the problem. Therefore, it is important that we invest more time with the governments to be in the lead. The second observation is that the short-term investment is really risky, because it could be backfire and generate more conflicts. And I see that the case of Iraq, I have been serving in Iraq for a few years. The case of Iraq is a good case to study, because social cohesion takes time. And sometimes the other conflicts that are created undermine the investment that we do in the systems. I think we need to manage our expectations. This is very important to manage these expectations, just to make sure we are expecting from different entities what should be expected. For example, let me talk about the UN. The UN, by definition, is intergovernmental. It works within the space that's given within the agreements of the intergovernmental entities. The work that is being done by the UN agency in any country is governed by the terms of reference agreed between the UN agencies and the government. Therefore, it should not be looked at as service provider. The UN is not service provider. It's not private sector. It's not advocator. In the first place, it is a political entity, intergovernmental entity that tries to shape out the policy directions, and to give space to others to work. Civil society is an advocator and could be doing service delivery if the other structures are not enough, and it fills the gap. It happens that has been filling the gap in many cases. And Lebanon is one of them, Palestine is one of them, where the civil society institutions were the key providers for services for a long time. And the final point which I would like to draw here is that it is time to invest in systems. In fact, in our discussion within UNFPA, we are currently developing our strategic plan for the coming 5 years. And the overarching statement for all our programs will be the investment in systems, because investment in systems can drive us from the distorted service delivery and ad hoc support to a more resilient, sustainable, impact-driven thinking of delivering the services and support for the governments, civil society, and the key actors in the different countries. Thank you very much.
Thank you, Dr. Shabaneh. We'd now like to invite you for a lunch reception in the lobby. And please, if you would like to pass by Auditorium B, we have the poster presentations. People have flown in to present their work, and they would love for some audience. So if you could kindly pass by Auditorium B. We should be starting back here in about 2:30, 45 minutes for lunch.
It's 1 hour and 50 minutes.
Apologies, we need to resume the next session at 2:30, clinical needs in transition.
Yeah.